Hello, everyone, and welcome to this webinar. I would like to formally welcome you now. The webinar is titled, What Will It Take to Deliver Universal Health Coverage and Strong Health Systems Worldwide in the Time of COVID-19? It is part of the Virtual Connect sessions as part of the Labour Party conference. My name is Anuj Kapilashrami, and I'm Professor in Global Health Policy and Equity at the University of Essex, and a long-standing member of the People's Health Movement, trustee of Health Poverty Action, which is the organization that has brought this conversation to you today. Health Poverty Action is an international NGO, and it works with health workers, activists, and communities worldwide with a fairly challenging and progressive mandate to address and tackle the root causes of poverty and poor health worldwide. We are very excited to have so many of you with us today, and I'm particularly excited to at the great lineup of speakers we have who will be touching on critical areas of universal health coverage. But before we start, there are just some basic bits of information to share. The webinar will be recorded. The event is an hour long, though I would have liked this to be several hours for us to discuss universal health coverage. So we will finish at 2:30 p.m. And because it's a tight time frame, it would limit opportunities for interaction, but we're very keen to hear your views and also take as many questions and comments in the final short segment of this webinar in our Q&A. So do post your questions. We'll see how we can incorporate them for the short Q&A after the speakers speak. Also join us on Twitter. You can see the hashtags on the slide. Now just to quickly set the scene for this session, we are here to explore what it will take to deliver UHC and deliver on our commitments to UHC and also to the strong public health systems worldwide in the time of COVID-19 and beyond. Now, the pandemic is a pressing reminder of the value of publicly funded, universally accessible health systems, as well as the long road ahead in meeting our SDG commitments, especially the target 3.8 to achieve UHC, including financial risk protection, access to quality essential healthcare services for all. Now, we know for which we only have 10 years remaining. Planning ahead requires a stock taking of where we are and a critical appraisal of gaps and our failures. With half of the world's population unable to access essential health care, another 100 million people worldwide being pushed into poverty for paying out of pocket for indirect healthcare expenses each year, we know there's a long and arduous road ahead. The trends towards rampant privatization and financialization of health markets, which are aided by governments and donors, make this task even more challenging. WHO predicted before COVID that without additional action, 1 in 3 people will still be going without vital health services by 2030 in a best case scenario. So while there was already a need for dramatic scale up of efforts, COVID-19 has been a further blow to these efforts. It has been an unprecedented test for health systems worldwide and poses a number of grave risks to the progress made to date towards achieving UHC. These include the pandemic's impact on other health services, especially primary health care. Delays in vaccination campaigns were reported in April, which were already due to see 13.5 million people expected to miss out on routine immunizations. A similar disruption of general maternal and child health services has also been witnessed, causing almost 1 million additional deaths of women and young children over the last 6 months. Now, the economic impacts of the pandemic are also worrying, and an impact on the overstretched workforce all contribute to these broader effects on people's health and lives. It also risks a shift to austerity measures, which we're already beginning to see, just as the need to increase spending on health is at its most pressing. Combined with the rise in nationalist politics, populism, donor nations turning away from global solidarity and funding of health interventions, this could really prove a huge threat to our commitments to UHC. In the UK, for instance, the DFID FCO merger already sets the scene for more self-interested approaches to UK aid. Yet, the COVID-19 all pandemic also offers us a unique opportunity to build back better. Health for all worldwide is increasingly recognized as vital for our collective well-being as we realize how interconnected our health is globally. So critical at this moment, we must make sure we harness growing momentum to deliver UHC and health systems which work for people and those left behind, especially migrants, refugees, indigenous populations who have been worse impacted by the pandemic. So today we will explore what is needed to get us there across healthcare financing delivery, role of donors, and the wider political contexts that help or hinder us, especially the drive for private and for-profit needs and well-being of people. So we'll be hearing from four great speakers, Preet, Kaur, Gill, MP, Rob Yates, Allana, Kembabazi, and Jessica Hema, before we move on to a very short Q&A. Now with that short setting the scene, I would like to, and I'm delighted to introduce our first speaker, Preet Kaur Gill. Preet is the Shadow Secretary of State for International Development and MP for Birmingham Edgbaston, and has been a champion of UHC. So I'm really excited to hand over to Preet. Over to you, Preet.
Thank you so much, Anuj. I really appreciate that. And I want to just say thank you to Health Poverty Action for having me here today and hosting this event, and also the great fellow panelists who I'm really excited to hear as well, and all of you that have joined us here today. But before I start discussing healthcare, I just want to give some context in terms of where we have been in terms of our response to the global pandemic from the UK government. And what's really been concerning since we've been appointed to the shadow front bench is actually seeing the sort of hands-off approach that this government has taken, outsourcing responsibility to the multilateral systems. Whilst that is right and it's really important in coordinating the response to the pandemic, it's equally really worrying that the government has actually bought up most of the vaccines per capita. And whilst, you know, we've been pushing really that when there is a vaccine available, it's got to be made available to everybody and the world's most poorest, because that's the only way that we're going to be much more safer. And in the midst of a global pandemic, one would not expect the government to, as Anuj said, to have been undertaking a merger, when actually we should be focusing all our efforts, not just here nationally, but the global collaboration and cooperation that is needed in terms of addressing this pandemic. Because if we're going to learn lessons from Ebola, more women died from maternal birth than they did from actually Ebola. And so existing programs are so vitally important. And that's why it was really disappointing to hear the government, just before Parliament rose for summer recess, announced £2.9 billion of cuts without any detail. And even now, we're still not able to understand where those cuts are going to take place and what the impact of that is actually going to be. What we are getting is snippets of information. For example, girls' education in Rwanda has been cut. And you know, it's going to be equally worrying that this is a government that is avoiding transparency and any form of scrutiny. As all of you will know, the NHS was created by a Labour government. It's an example of how universal health coverage, something that we should all be very, very proud of. And it's rightly become a national treasure in the United Kingdom, regularly ranked as one of the most important issues at elections, but also praised around the world. The NHS has allowed all of us to access quality healthcare, free at the point of use, regardless of our income. And during the COVID-19 pandemic, we've seen how the UK has, despite all this, struggled with a health crisis. And for far too many people, though, across the world, their right to quality healthcare is far from realised. So imagine what it will be like for countries where there's only 13 ventilators to support the whole nation, for example, in Sierra Leone, or just 15 intensive care beds like we've seen in Somalia, or one doctor per 2,000 people in Bangladesh, which is one of the lowest rates of formal medical care in the world. And this is relevant now, but it also shows us how much work we have got to do to support other countries to develop a very strong health systems in the future. And that's got to be part of our building back better. This crisis has also highlighted a distinction between the mega rich, who avoid paying their fair share of tax and lobby governments to line their own pockets, and ordinary people who play by the rules but are hamstrung and pushed down by factors which are really outside of their control. In the UK, our dependency on universal public services such as the NHS is at the forefront of our minds, but the only way to sustain services is for everyone to contribute their fair share. But sadly, public services has been under attack over the past 10 years, not just here in the United Kingdom, but all around the world. And as this global pandemic is showing, we are only as strong as our weakest link. So we have to work together. We have to work across national borders if we are to overcome this pandemic. And it's resilient public services that really do have the opportunity to save lives, not only through their immediate work, but also in their cumulative efforts to create a much more safer, healthier world. And again, using COVID-19 as an example, preventing a crisis, as we all know, is quicker, it's cheaper, and it's much more effective than trying to deal with it once it has spread. And a lot of this stems here in the UK to a lack of prioritisation, a lack of investment in preventative services. The NHS only contributes 5% of its budget towards preventative services. The UK, though, has had no global health strategy since 2013, and there have been a number of warnings that funding on health system strengthening is minimal. And once again, COVID has shown that we need to be thinking much more broadly about health, learning from other countries, sharing our information and working together collaboratively to overcome health crises as quickly as possible. But this is also true of the day-to-day work that happens. Prevention and early intervention is much cheaper and more effective than treating systems, yet access to primary healthcare facilities remain extremely difficult for many to reach. I mean, the very fact that 3 billion people around the world still don't have access to wash facilities within their home, and in the midst of the global pandemic, that's one of the measures that will keep them safe, is extremely concerning. And if recent trends continue, excluding the impact of COVID-19, up to 5 billion people will still be unable to access healthcare in 2030. Many of you will know that there was a UN report last year on healthcare, which found that, unsurprisingly, the biggest health service gaps were in the poorest countries and in those affected by conflict. And when we're talking about UHC around the world, this doesn't mean that we're talking about transposing or exporting the NHS, but actually what we're talking about is working collaboratively with partners around the world to promote universal health coverage, which provides healthcare that people need, but it's funded through progressive taxation, is free at the point of delivery, and leaves no one behind. And this isn't easy to say that the UK shouldn't use the wealth of experience and expertise in universal health systems to work with governments or civil society groups and other stakeholders across the world to support the development of public health systems. We know, though, that the implications of universal healthcare stretches far beyond health. For example, it is crucial for gender equality. We've seen that women around the world take on a far greater burden of unpaid care work for friends, for relatives of all ages. So when a fully functioning health system is in place, where care work is available and treated as the vital job that it is, women are freed up to engage in paid work opportunities, political decision-making, education, and other aspects of life that might formerly have been restricted to them. But before I finish, I want to touch on financing and one key area really around taxation. The upfront cost of healthcare is obviously going to be expensive than not having it. But as I mentioned earlier, even removing the moral duty we have to try and ensure everyone has access to quality healthcare, the additional gains over the medium and short term for a society are plain to see. If lower income countries, though, are to have any chance of making up even part of the gap required for them to bridge the distance between where they are now and healthcare for all, then global institutions and wealthy countries will have to provide some support. And this stretches beyond a narrow idea of aid to acknowledging the impact that other policies will equally have, for example, tax avoidance or debt burdens are having. And we know that in the UK, the taxation is needed to fund our public services. On tax in the global south, just as in the UK, tax avoidance and evasion occurs, and it takes money away that could be and should be invested in public services like health out of a country, and it ferrets it away to avoid paying what is owed. To be honest, it should shame us all that in many instances, the money hidden away is enabled by British overseas territories like the British Virgin Islands. I will leave it there because I know we've got lots of speakers, but just to say that the healthcare for all is a vital step to create a better, safer, fairer world for all of us. And it's on all of us to make sure this remains high up on the agenda. Thank you.
Thank you, Preet. That was really sharp, and you really hit to the heart of the debate, highlighting disturbing trends in cuts, attacks on public services, and also the need for transparency in budgets and progressive taxation. I was really heartened to hear about the moral imperative on countries in global north to take a lead in this. With that, I'm very pleased to hand over to Rob Yates, who is the director at the Chatham House Center for Universal Health, and very excited to welcome him and hear his views and this phenomenal experience of looking at UHC in other country contexts as well. Over to you, Rob.
Thanks. Thank you very much indeed, Anuj, and thanks, of course, to Preet as well. And I'll be sort of developing a number of Preet's discussion points, particularly around financing and the politics of health financing for universal health coverage. So next slide, well, first slide, please. So I think we first of all need to be clear about what we mean by universal health coverage, because people define it in different ways. This is a simple definition that all people receive the quality health services they need without suffering financial hardship. So you see, there's nothing about health insurance here. People often associate health coverage with health insurance, but this is very straightforward concept. Everyone in the country gets the services they need without suffering financial hardship. Next, please. And you can see that really what it's about is all about equity and fairness. And this is, takes it straight into the political realm. Because if we are talking about everyone being covered, it means nobody is left behind. And we've seen in the pandemic here, population groups that have been left behind. Homeless people, were badly covered to start with. People in care homes have been left behind. So it's absolutely critical that everyone gets the health services they need, and that they're allocated according to need. That some people objectively need more healthcare than other people. So that people in care homes and pregnant women, as Preet has mentioned, should be getting more healthcare than other people. Then there's this vital aspect of the financing being done according to one's ability to pay. If you're going to have a situation that nobody suffers financial hardship, then logically it means that rich, healthy, wealthy people must cross-subsidise services for the sick and the poor. And this is something that we all recognise in the UK and we're very proud of with the National Health Service. Next, please. Now, this issue of health finance of universal health coverage has historically been very controversial. And about 20, 30 years ago, you had the likes of the World Bank and IMF telling countries to cut their public spending and push the financing burden onto households. Now, that was fundamentally wrong. And but now, thankfully, I think all the agencies, and this is Gro Brundtland, who spoke at the high-level meeting on universal health coverage last year, saying the only way that you can reach universal health coverage is through public financing. So that's the state forcing healthy, wealthy people to cross-subsidise the sick and poor. You'll never do that in a free market for health services. Next, please. But that process of moving towards universal health coverage and in effect socializing the health financing system is inherently political. I mean, it's obvious that people will resist it. I mean, it's being resisted big time in the United States and in South Africa, and vested interests, and including the Tory party, tried to block the NHS, of course. So it needs to be led from the top, it's a head of state issue. And this is why Dr. Tedros is championing universal health coverage, focusing on political leaders. It's all about political commitment. You need a political commitment to get the public financing. Next, please. So now the big question is, how do you generate that political commitment? And you might think, this is going to be particularly difficult at the moment in the midst of this crisis to get more being spent on your health system. But the interesting thing is that, and I'll sort of show you in a moment, so many great UHC systems have come out of a crisis. And my goodness, we are in this almighty crisis at the moment with COVID-19 that requires urgent action from the head of state and across government. And we're hearing announcements by the government today around this. People in particular want access to health services. We all want tests. We all want vaccines. Everyone wants them. And they want to be protected from the costs of that thing. That if you need a ventilator, the actual cost is thousands of pounds. But that we insist here in the UK that the state provides for that. And we recognise, particularly with this infectious diseases, it has to be a universal entitlement. So homeless people, you know, society, people who tend to get left out typically, that's in no one's interest that that continues. It has to be universal. And people want to see results quickly. All political leaders are under tremendous pressure. Next, please. And you can see that you know, in this crisis, you know, that some leaders are stepping up. And, you know, I just want to sort of show some of the history of health systems that have come out of crises. So the Thai health system came to fruition after the Asian financial crisis in 2002. Prime Minister Thaksin was told he couldn't do this. He said, no, I want to bring healthcare to the masses, you know, even despite this crisis. Very, very successful health system dealing with this crisis particularly well. Next, please. I just want to sort of run through one or two of these. Now, yes, yeah, you can keep those on together. Thanks very much. China, very interesting, had historically a very effective primary healthcare driven health system. In the 70s and 80s, they allowed private financing to take over. But it was the SARS crisis of 2002 that made the Chinese realize that they needed to re-socialize the health financing system. And you can see that government spending increasing and crowding out private voluntary spending. And China now has like 96% health coverage. And despite the early problems of the epidemic, is again dealing with this crisis very well. Next, please. And now here's an interesting country that it seems to be on the verge of using this crisis to catalyze its UHC reforms. And that's South Africa. I'm not sure, there you go, that's the whole photo there. That's President Ramaphosa saying that they are going to initiate the national health insurance, or it's all tax finance in South Africa, coming out of this crisis. And we should be supporting countries to do this. This is exactly the time to be doing it. Next, please, because another interesting example, of course, a country that really ought to be making the transition to UHC, and that's the United States. And you see on, sorry, sort of jumping around a bit here with it's the technology. Now, if you could just go back one very quickly, very recently in a town hall meeting, Hillary Clinton was saying to Joe Biden, use this crisis to introduce universal health reforms. That's the slide. So she absolutely gets it. You know, Joe Biden hopefully is going to be coming to power soon, and this would be the time to grasp this. Obviously, he hasn't been as bold as maybe Bernie Sanders has been, but now is the time to do this. What I was going to say, if we can bring the slide up, that we've got the situation that the UK is really, really good at this. We were one of the first countries to use, you know, the crisis of the Second World War to introduce the NHS when we were bankrupt. We were a post-conflict state dependent on US aid, and tremendous success. And of course, there's Nye Bevan on the launch of the NHS. And when we celebrated the Olympics in 2012, it's one of our greatest achievements. We should be doing a lot more at celebrating this. And it's really shameful, I think, that the current government isn't doing this. Next slide, please. Because 10 years ago, we were leading the world on universal health coverage. Gordon Brown, in particular, at the United Nations in 2009, encouraged 6 heads of state to announce they were going to extend the provision of free health services, particularly for pregnant women and children. And this is what people expect us to do. And this is exactly what we should be doing. And, you know, very much feel that an incoming Labour government, that it's a no-brainer that, you know, that this is what we should be doing, and people would really welcome this. So I think final slide, if I'm not mistaken, that really this is the biggest crisis we've had in over a century. Across the world, people are looking to their political leaders, particularly around access to health services and financial protection, you know, universal health coverage. So we should be out there helping President Ramaphosa, helping the Prime Minister in Bangladesh to launch UHC reforms. And I'm sure we're going to see this happen in the coming months. Thank you.
Thank you. Thanks, Rob. Really very important points and a very helpful reminder of the tale of two UHCs and the different directions that one can go into, whether you go down the care route with equity considerations at its heart, or you go down simply extending health insurance programs and looking at coverage in a very reductive way. And thanks for also showing that we have done this. We have had examples where governments have done this differently. I'll come back to some of these points later, but I want to move on to Allana Kembabazi, who's the programs manager and is leading on the Right to Health for the Initiative of Social and Economic Rights in Uganda. Over to you, Allana.
Hello, can you hear me? Great.
Yes.
First of all, I'm really excited that this discussion is happening. As someone coming from one of the countries that Preet described, I want to start us off by the Initiative for Social and Economic Rights monitors economics and social rights and holistically works to advance them through research, documentation, budget advocacy, and a whole host of things. And the health coverage, the health program strongly believes in the idea that everyone should be able to access healthcare as a fundamental human right. And I wanted to, if you move the next slide, just give you a brief background on Uganda's context in terms of health. A lot like what Preet was saying, we have huge infrastructure problems. We lack hospitals. A district, I think you should understand a district because it's a very similar sort of, we borrowed a lot of our governance system from you. But, you know, when I say 39 districts at hospitals, it means for over 50,000 people, there's no hospital. We had 55 functional ICUs for the whole country. And it's only during COVID that they began procuring 145 others. And we need 25,020. We have 181 government ambulances. When you couple in the private, where you can't really dictate where they should go. But if you added them up, you'd have 411 for the whole country. And so a lot of these are systematic infrastructure problems. Next slide, please. And that slide also just gives you a breakdown of the facilities in the country. And as you will see that the areas, the rural areas, the hard to reach areas like the northern region are often have less facilities, particularly less, the government plays a bigger role. The private don't really go there because it's just not very profitable. The eastern region as well, which is another region which is very poor. And a lot of this is systematic. If you go to the next slide, we've had systematic underfinancing of the health system. And please go to the next slide. If you look at our budget, it's between 6 to 9% of the national budget. That's the percentage that goes to the health sector. We rely quite a bit on donors, and as a whole, because of a systematic underfinancing, we've seen real issues around the quality of the public health system. Health workers were threatening to go on strike last year because of lacking essential equipment like gloves, and this has been more pronounced during the pandemic. You know, just lacking essential medicine and supplies. And like I said earlier on, the fact that we only have 55 functional ICU units or 411 ambulances in the whole country are all tied to systematic underfinancing. And again, there's been this discussion within the country where they've thought about health as a consumptive sector. And so I very much appreciate the earlier speakers that were showing how it's not just a moral thing that you should do. It's actually vital for everyone's well-being, for national security, but for so long, until COVID, it was thought of as a consumptive sector. The next slide, please. And we've been seeing a shift where people have said, well, the public health system is not working, we should switch to the private health system. This has been pushed a lot by donors, including donors like the World Bank, without examining why the public health system is not working. There's been the idea that the private sector will be more efficient, that they will reach where the public cannot. But there are real concerns around that. For example, we have, a recent example of this is a decision to invest $379 million in one hospital. Remember, we have 39 districts, like I said earlier, without hospitals, but $379 million in one hospital that is going to charge international prices. So you will be charged what you would get if you travel to, say, India or wherever else people go, because a lot of the, particularly non-communicable diseases, people often travel. And this money has already been mismanaged, but there was a decision to allocate all that money to one hospital. Next slide, please. And there's also been a whole move as a whole towards public-private partnerships. They've been thought of as a win-win situation. The public, in Uganda's context, has been putting in some money, and the private will deliver. But other times they say, if we use private finance, we will deliver public good. We did a report on this, which you can find on our website. The next slide, please. But this is actually, it's short-sighted and flawed. And I want to give you a good example. So Uganda has, well, at the last household survey, had 29.4 million people that were poor. And there will be, in light of COVID, an additional 2 million people or so. But when you looked at the distribution of poverty across regions, it was in the east and the northern parts of the country, which I've highlighted in blue. The next slide, please. But if you look at the facilities and who owns the health facilities, for example, you will notice that in the eastern and northern region, you're looking at this, if you're juxtaposing the government versus the private for-profit, which is PFP, and the private not-for-profit, you will see that they're not going to the poorest areas. For example, you will find that there's only, there's like no private not-for-profit. Health center for is where you'd give birth, you'd be able to handle a whole host of conditions. There's none private for-profit health center for in the northern region. The last time this master list inventory was taken, and only 2 private not-for-profit. And if you just as a whole, if you look at the overall numbers, you will see that in the northern region, which is the most vulnerable region in the country, the government is there, 721 facilities. You only have 136 private for-profit and 70 private not-for-profit. So again, the private, don't go to these areas because these are the poorer areas. You won't be able to profit and stay in business. And that already begins to make one question claims that the private can deliver where the government cannot. Next slide, please. And another example of this has been a tendency to say we'll ignore the public health system and we'll support some of these piecemeal approaches, for example, vouchers. In this case, this was a voucher that was supported by the World Bank. And I know that a number of donors have been supporting vouchers where you pay 4,000 shillings, which is about $1.50, and you're able to give birth in a health facility. And it sounds really good on paper. And people have said, maybe this should replace the public health system. And remember, Rob and I had a back and forth about this earlier on this summer. The next slide, please. But you find that they actually do not reach the most vulnerable. This is just some background around the project. It was $17.3 million US. Remember, we are a country where we are grappling with lack of ambulances, which would just having those nationwide would cost $11 million US. But $17.3 million US was spent on this project. Next slide, please. And like I said, the poor did not reach, when the audit was done, only 32% of people who benefited could be classified as poor. Next slide, please. And, they have high administrative costs. Next slide, please. As a whole, we have to really reflect about what we mean when we say we're talking about universal health coverage. We throw it around loosely in Uganda's context and in a lot of, just everyone. It's a very sexy word right now, but the idea of leaving no one behind means that from a human rights perspective, at the very least, you should be thinking about who are the poor and who are the most vulnerable. And the private sector, the public system rather, is the first point of call for those. And we saw this during COVID. We had a lockdown to combat COVID, which meant movement was not allowed. And in areas where there were public facilities, people could go. And in areas where they were not able to now travel the long distances. A number of private facilities were detaining patients because they could not pay. As a whole, the country has been able to successful, semi-successful, I guess, we'll see, but we've been doing pretty okay in combating COVID because the public health system is where it is being managed predominantly. It's only recently that they decided to allow private facilities to begin to, you know, conduct tests and refer to the public health system. And a number of private facilities began to send away patients because it was not, they just didn't want the stigma of having had a COVID patient to deter other patients from coming because they needed the money and the revenue. A number of them have point blank told people, if you have any of these symptoms, bye, please don't come here. And so, you know, in this period, and we're in a period also where, like I mentioned, 2 million additional people are going to be poor. We live in a country where there are high out-of-pocket costs for healthcare if you do go to the private. And I think it's imperative that we sustainably resolve this. And people, donors, governments have to really invest in the public health system. I will end that by just making a few recommendations. Next slide, please. And it's just really that, one, invest in the public health system. Be wary about this new sexy trend of public-private partnerships, of private actors in health going to work for the poor. And what we've seen, like I've said, is that they do shift resources away from the public health system where the poor and vulnerable really rely on, and which is has been systematically underfinanced, and they shift them to those who are better off. And so refrain from requiring private actor involvement if you do finance. For donors or other entities that are coming in, consult with affected groups. Ensure that there's due diligence. Will your support actually help the most vulnerable? There are a lot of us here who are really advocating for human rights impact assessment because it is a whole lot more holistic. And I just also want to underscore what was said earlier on when thinking about the role that you play beyond health and thinking about things like illicit financial flows, right? And the ways in which, whether or not your government is enabling systems that allow that to flourish, because it then means for countries like Uganda, we're completely depleted of resources that would go towards healthcare. Thank you.
Thanks, Allana. And we'll come back to some of these recommendations in the Q&A session, hopefully. That was really an excellent, more deep dive view of specific countries. And the gaps and challenges that Uganda is confronting with its underfinanced health systems, also how systematic disruption of these public health systems has taken place through tools like PPPs and piecemeal approaches. Thanks. Now we'll move on to hear from our final speaker, Jess Hamer, who is heading the policy and campaigns at Health Poverty Action. Over to you, Jess.
Brilliant. Thanks so much, Anuj. And thanks also to the previous excellent speakers we've heard from already this morning. So it's clear from the speakers who've spoken so far that we really know what needs to happen to deliver universal health coverage and strong health systems. And that's a massive scale up of investment in public health systems. And we need to make sure those are financed in the right way through general taxation. And we need governments and donors to avoid pushing private for-profit approaches which risk prioritising corporate wealth at the expense of people's right to health. So for my short presentation, I just want to pick up on a number of critical and growing threats to progress towards achieving UHC and the UK's role, and the action needed to guard against these now. And the first of these has already been mentioned, and it comes from the merger of the Department for International Development with the Foreign Office, creating a new government department. So while we know that commitments to spending 0.7 of GNI on aid are so far being maintained, the central risk of the merger is that it really pulls UK aid further in a direction which prioritises British interests, whether these are corporate or political, over aid's contribution to poverty reduction and, of course, to universal health coverage. So the Prime Minister announced the merger in a speech which really made this approach clear, setting out a vision for UK aid which works to safeguard British interests and calling into question why we currently spend so much in countries like Tanzania and Zambia over countries of more strategic interests like the Ukraine. So what does this practically mean for achieving universal health coverage and strong health systems and the global pandemic response? Well, firstly, aid accounts for 32% and 43% of health spending in Tanzania and Zambia, respectively. In a number of low-income countries, the UK is supporting government health systems through its bilateral aid programmes. So a shift to spend aid in more supposedly strategic countries than these could have dire impacts for health systems already struggling with resource constraints prior to the pandemic. Secondly, under the auspices of a mutual prosperity and national interest agenda, we've already seen increasing amounts of UK aid channeled to the exact risky for-profit approaches in healthcare, which Allana has just so eloquently described, which are fundamentally incompatible with universal health coverage. So, for example, the CDC Group, the UK's private investment arm for UK aid, now lists health as one of 7 of its strategic priorities for its profit-generating investments. But we know that CDC healthcare service delivery investments are predominantly in expensive private for-profit hospitals. These can either feature expensive fees, so one affordable chain, affordable in inverted commas, charges $300 to deliver a baby with a midwife, and will add an extra $50, $70 for incubators, medicines, additional costs. Some of these hospitals explicitly target the international medical tourism market, which again, Allana mentioned, making fundamentally clear that they are targeting the super rich, not people in poverty. There's even been reports of one of the CDC funded hospitals, Vikram Hospital in Bangalore, India, refusing to treat patients with suspected COVID and being served a notice by the government for this scandalous behaviour. Then beyond the CDC, initiatives like the Prosperity Fund's £79 million Better Health programme, which was already channelled through the FCO prior to the merger, incorporates the dubious aim of seeking opportunities for UK and global businesses, whilst also somehow seeking to tackle non-communicable diseases through improvements to health systems. It's assumed that the opportunities for business might arise from digital health or research and development components of the programme, but it's really unclear how such opportunities will avoid spiralling costs for governments, either through public-private partnership approaches, or how those costs will fall on the people, how it will avoid the costs falling on the people seeking the health services, which obviously would run directly in contradiction to UHC. There is also a risk that through the general shift in the direction of UK aid, more aid for health is channeled direct to private companies. So the UK has faced growing scrutiny already for spending hundreds of millions of pounds a year through private consultancy firms that are often based in this country. In the last 2 years, 95% of the UK aid for health, which did go to private actors, has gone to companies based in the provider country, which is the UK. This trajectory essentially sees us risking a return to tied aid in all but name. At the same time, Southern actors have been found in a recent Action for Global Health report to receive very limited direct UK health aid, and aid to governments in health has declined by more than half since 2010. Finally, and as Preet already mentioned, we know that UK aid programmes are facing £2.9 billion worth of cuts this year. At Health Poverty Action, we have programmes in 18 countries, and we're hearing reports from the ground of uncertainty, delays to programme renewal, and the stretching of budgets over long time periods. This is happening, for example, in our programme in Somaliland, where Health Poverty Action is working to strengthen the health system and support access to healthcare. The programme supports around half of the population in a country where the UK is the main donor. So it's really vitally important that programmes providing such core public health system support are protected from disruption and cuts, and that the areas where DFID has historically demonstrated real global leadership, for example, mental health, which is an issue of increasing importance in the COVID pandemic, these must be protected too. So we need to steer the cuts towards the unproven, untransparent, profit-seeking approaches adopted by the Prosperity Fund, CDC Group and others. But we also need to contextualise the recent shifts in UK aid, including with the historic and continued extraction of wealth and resources from the Global South, and the mechanisms which maintain concentrations of power and wealth in the world today. So we need to really recognise that aid is just one piece of the puzzle when it comes to the UK's role in supporting the achievement of universal health coverage. We need to look beyond aid and scrutinise the way the global economy is structured to benefit the wealthy at the expense of people in poverty. And we need to take bold action across the broader issues at play, which undermine the struggle to realise universal health coverage. And as Preet mentioned earlier, this includes action on global tax dodging, where the UK plays such a central and unjust role, as well as across unfair trade agreements and access to medicines policies, where corporate power and wealth are put first. Labour has an opportunity to really set out a bold vision for the UK's role in the world, for UK aid and beyond. And I was really encouraged to hear the strong words going beyond aid from Preet earlier in the session. We have a real opportunity now to unify the UK's efforts behind tackling the spiralling global inequality, which we are seeing reach dizzying new levels as the wealthiest just profit day by day from the pandemic, and the most vulnerable face the worst challenge in a generation. So we're really excited to see Labour champion a new narrative of global solidarity, and hope to see a movement built and strengthened for taking on the power structures which are undermining our public services worldwide, here in the UK as well as the Global South. And we want to see the building of these alliances that are needed to take action on the networks of power which support unfair tax, trade and debt practices. This will advance the struggle for UHC in the time of COVID and beyond. I'll stop there. Back to you, Anuj. Thanks.
Thanks, Jess. Really very interesting and fascinating findings, especially on the insights on into the aid for health, which was the last piece of puzzle that we wanted to address today. I think especially the issues regarding how governments and donors through their development finance initiatives are enhancing those inequalities, privatizing healthcare further, and also what are the implications of this for universal entitlements in health. So thanks for your intervention there. I want to now turn to a short Q&A session. I'm conscious of time, so we have about another 10, 11 minutes for Q&A. And I would want to turn to this panelists, and I think I'll start with Preet. It was really helpful to hear from you on what that vision is, but I think if you can also specify what actions should and would Labour be taking to facilitate more countries in the South achieving UHC, given what we've also heard on how the UK government and CDC have been quite complicit in extending those inequalities. So what is the vision of the Labour government in enhancing this, and also its role in influencing international institutions?
Thanks, Anuj. And I just want to say thank you to everybody that's contributed in the chat. There's been some great questions, and unfortunately we don't have enough time for a discussion on this. We are really committed that part of building back better, we've got to create a movement around a global health strategy. Rob is absolutely right. The Gordon Brown's strategy 2009 to 2014 really had some very clear goals and aims. But actually what we saw from Gordon was that leadership, that political will of working with leaders across the world to absolutely get them to understand and support that. And of course, I noticed somebody put in the chat about, Labour's view in terms of, aid. I mean, I think that's pretty much a conservative view of seeing aid as charity. I think Labour has always been very clear that what sets us apart from the Conservatives is that we see development as being long-term, as addressing not just poverty, but really going to the root cause and of addressing inequalities. And that's something we are absolutely committed to. I think all of us agree that there's got to be a global health strategy. going forward? How do we build that movement? For us as the front bench, we are working with our sister parties to create that understanding, that vision. We'll be building a campaign around this. This is something we're going to have to do as a longer term strategy. It's about how do we create people in the United Kingdom as well to have that global solidarity with people across the world, absolutely understanding that this is not going to be the only pandemic we face. So how do we get the world and the UK to be more prepared for future pandemics? And that means, of course, part of the access to healthcare is going to be really key. But as I said before, I think many of our panelists have also touched on, it's about going beyond aid. And for me, you know, the development, UK aid is only a small part of that, really. So thinking about debt burdens, thinking about tax justice, trade policy, intellectual property rights, what that means is that obviously working very closely with our colleagues from other departments so that there is that policy coherence across the piece, as opposed to just us trying to do this and them clearly trying to do something completely different. So I think, you know, we've also got to have scrutiny. I think the thing that concerns me the most with this merger is that actually we don't have an adequate scrutiny function. The government's not been clear in terms of how we're going to be able to hold it to account, because we've got to look at what the impact of development is going to be on by this government, and especially building back better. How are they going to absolutely push and be promoting and supporting UHC? And of course, we've got to move away from this private sector mentality we see in India. I see it far too often. I hear about it where, you know, those that can afford access to healthcare, you know, absolutely can, but it's the world's poorest and the most vulnerable that won't have access. And if they do, it's facilities where there isn't really the very things that we expect around hygiene, but the qualifications of and standards that are required, and that cannot be right. You know, we can't continue to have this unequal access to vital universal healthcare, especially given the pandemic. I mean, how many deaths we've seen here in the UK, but of course across the world, and you know, we haven't really seen the peaks. I mean, I think it's very concerning what we're hearing in India in terms of the rate of infection, but even then the information coming out, of course, if you live in slum dwellings, then you are far greater risk than actually if you are able to effectively social distance and take out other measures within your home. So I think, I also mentioned earlier, I think one of the really key areas is around tax evasion. This is something we've absolutely got to tackle. I feel so strongly about this. You know, we cannot allow, you know, private sector and you know, extracting money from places where they should be paying tax so that that can be invested in public services is absolutely wrong. I mean, the private sector's got a lot to do and we've got to push. But I'm really, really excited. I'm really excited about absolutely pushing and making the call for global health strategy, working with partners across the world. We're working with panelists on this on this event today, especially with Rob. I know he's been really passionate. It's something he's been calling forward to. So I really look forward, as does the front bench, in terms of really pushing for this call to action. Thank you.
Thanks, Preet. A number of points which I really want to come back to, and but I think what we've heard so far, and it has really put forward, there is a vision, there's a progressive vision that we all share, and the panelists share, and many of the audience today will be sharing around UHC and what needs to be done. But there is also almost a regressive trend that we have been moving away from those promises. I think what I want to hear from all speakers is how do we reverse the regressive trends in financialization and privatization of healthcare markets, and what can we do to ensure that this pandemic results in a renewed momentum for publicly financed and delivered healthcare for all worldwide. Rob, do you want to start?
Yes, thank you very much. And you know, yes, the crisis is absolutely terrible, but it undoubtedly does present an opportunity to argue the case even more strongly that a publicly financed universal health system is the way to tackle it. You know, that also combines public health services better with the health system. And you know, this has been one of the failings in the UK, the fragmentation between the public health world tackling the pandemic and the NHS, both of themselves great institutions, but not brought together particularly well by this government. And lots of governments are finding exactly the same thing at the moment. So I think that the crisis that, you know, that is at that level, the head of state level, really calls upon us to be helping them recognise that their best strategy to deal with this is a publicly financed universal health coverage system, prioritising public health services, primary healthcare services, making sure that everyone gets the services, and that this can bring tremendous health benefits, obviously, in terms of, sort of people surviving and all that, economic benefits in terms of creating jobs and sort of protecting the economy, and there's a whole plethora of economic benefits, but political benefits as well. It glues societies together. The Cubans are celebrating their system, the Thais are, there are lots of health systems actually dealing with this relatively well and are very proud of what they're doing, and it's a great thing that. And so I think this is what we should be doing, and going in at that high level, ministries of finance and heads of state, which calls for, that high engagement from our Prime Minister and our Treasury, which we've just been patently failing to do. And I think it's the fact, I was fortunate to be in a meeting last year with President Ramaphosa discussing the South African health reforms. He was unaware that the NHS had been launched in the midst of a crisis, and was very, very interested about that. Now, why isn't the UK government celebrating this and supporting countries at this very difficult stage? So I'm, aiming high and trying to be catalytic, I think, is the trick.
Thanks, Rob. Allana and Jess, could you be very brief? We have like almost a minute remaining before I wrap up. Thanks.
Sorry,
yes.
I do think that it's important to push back against that. Like Rob said, this is a defining moment. We've seen really wonderful systems come out of moments like this. And I think the great thing about this moment is everyone recognizes that if the poor market woman cannot get healthcare, then as a society, you're all collectively screwed. And I think it's time to really push back on that and put emphasis, because like I said, it's not that we live in a world of unlimited resources. Decisions have to be made, and every time you prioritize the private sector, it means you are in a lot of ways diverting what would be valuable resources from the public sector. And we have to think about who needs the support the most. It's the most vulnerable. I also think it's really important that, and it came up in the chat, that information about some of these things trickles down to the communities, to people like me and people in Uganda, for example. In the chat, someone was talking about how public-private partnerships were a mess in the UK, but that's not the message we are getting. They're being pushed here quite aggressively in Africa by institutions like the CDC, and they're being told it's a win-win. Our leaders are being told it's a win-win, and it's a few organizations like us that are beginning to document and saying, wait a minute, why are you bringing this model in at this point? And so I do think there's a lot that can be done in terms of collaboration, in terms of articulating some of these things and having them there in the literature. Things like vouchers, for example, when you read all the studies by the World Bank and everyone else, overwhelming success. It's a great example of how the private sector can reach the poor until you're on the ground. And so I think it's important that this information is also documented, such that, policymakers in countries like mine who are grappling with what is the best way to address this are not often misled. And finally, I think beyond access to information, just really encouraging participation in the communities. We often have a system where it's top down, and we get to know, we will have public-private partnerships, so we'll have this, and no one actually consults and says, what do you need? So I think it's really critical to address those three things to ensure that we have resilient public health systems.
Thanks, Allana. Jess, any last thoughts on that?
I'll be extremely quick. Thanks, Anuj. So I'll echo what Allana said. We need the reality of the for-profit private sector in health exposed. We need to myth bust what this looks like, what agenda donors are really pushing here, and what this looks like on the ground. But I also think we need to build kind of global champions on this agenda, and we need stronger alliances worldwide. We need to support civil society to really mobilize and unify behind public services at this time when there's a real opportunity. And I would just say as well, those movements, they need to be shifting to be built more on solidarity. This can't be about a north-south divide anymore, or a paternalistic relationship. Those days are over. These issues affect us all. We need to be linking the outsourcing of test and trace in the UK to the privatisation in Uganda. And we need to build a global movement that can really speak to the root causes of poverty and poor health, to build that solidarity.
Thanks a lot, Jess, and to all the speakers, really very powerful commentaries and insights from you all. I will not attempt a summarizing everything because we're already over time, but I'm really pleased to see this enthusiasm from both audience and speakers, and the commitment to a universal system, which is based on structural reforms and redistributive justice rather than incremental tools and attempts to change the status quo. We really need to see the pandemic as an important milestone to completely redefine the norm towards UHC and take a very different path from what many countries have been on. So thank you. It is, I mean, some of the examples that we heard around resocializing health financing are really key and need to be celebrated rather than the incremental celebratory applauses for our doctors and frontline healthcare workers. So thank you all. The recordings will be available on the HPA site. You can also reach out to Health Poverty Action's team using the email addresses on the screen. And we will be sharing this recording with you all tomorrow. Thanks a lot to the audience, and again to the speakers. Thanks all.